My name is Miguel Cortel. I'm one of the third-year medical residents here in Emerge in the FRCP program. And thanks for coming for my grand rounds. Today I will be talking about responsible antibiotic use in the emergency department. And my supervisor for the talk was Dr. Yadev, who's joining us as well. Now, before we get started, by a show of hands, who here has prescribed antibiotics in the last week? Yeah, so thankfully this is relevant then. The talk will be divided in two parts. The first part, it will be an overview of antibiotic stewardship. We'll cover three things. We'll look at different concerns that are associated with antibiotic overuse. We'll also take a closer look at what our antibiotic prescribing trends in Canada are in our local institution. And we'll delve into some concepts about antibiotic stewardship and how this applies to the emergency setting. In the second part, we'll explore three clinical cases where emerging evidence suggests that the role of antibiotics is either questionable or controversial. The first case, it's asymptomatic bacteriuria, and we have a protocol for this. And we'll take a closer look at patients with an indwelling catheter. Secondly, we'll look at dental pain without overt signs of infection. And lastly, we'll discuss uncomplicated diverticulitis. So with that, I think that we hear quite a bit about issues surrounding antibiotic overuse, but most of the time, these concerns are brought up by either the press or infectious disease colleagues or pharmacy. And many of you might be wondering, why does this matter to me as an emergency doctor? Where there are three main unwanted effects that we see in the emergency room from antibiotic overuse. First, we see their toxic effects. Second, the promotion or selection of pathogenic bacteria. And thirdly, increasing antimicrobial resistance rates. We'll talk about each of these briefly. So with regards to their toxic effects, I want to highlight a couple of studies. There was a study that looked at nursing homes in Ontario, published in 2015, where they divided nursing homes into high-prescribing nursing homes versus low-prescribing nursing homes. And what they found is that residents in the high-prescribing nursing homes were associated with an increased rate of antibiotic-related adverse effects of 24%. And this is regardless of whether that resident received an antibiotic or not. We also know that roughly 10% of all adverse drug reactions are hypersensitivities, one of the most common reactions from antibiotics. We don't have high-profile Canadian data at the population level, but national injury surveillance data from the United States between 2004 and 2006 shows that of all the patients who visit the emergency room with an adverse drug effect, 1 out of 5 of them is due to an antibiotic. And this represents over 140,000 annual emergency visits for antibiotic-related adverse effects. And 79% of these are allergic reactions. Secondly, we see the effects of the selection or promotion of pathogenic bacteria. The most common example of this that we see is C. diff. Basically, we have this bacterial flora in our body. It is predominantly in the gut. And with the introduction of antibiotics, it changes the environment such that it favors invasion by C. diff. At TOH, between 2014 and 2015, there were 130 patients that were identified as C. diff, and this number increased to 167 patients between 2015 and 2016. And what's important about this data is that it doesn't capture all the patients that we see in the emergency room that we sent back to a nursing home or retirement home who might be colonized with C. diff. The third and probably more important unwanted effect that we witness is that of increasing antimicrobial resistance. Public Health Ontario data that was published in 2015 highlights this trend. It shows that the rate of MRSA in Ontario has more than doubled since the year 2000. The bar that's missing in 2014 was due to the survey not being administered in that year. And when we scrutinize this data even further, we can see that different jurisdictions in Ontario are seeing different rates of increase of MRSA. In fact, the area that has seen the highest increase is postal code K, or our own postal code. It has seen an increase of 66% of MRSA from 2013. And the same is true for other antimicrobial resistant strains. VRE, for instance, has seen an increase in the colonization rate as well. And although the data stops at 2011 due to a lag in publishing, you can surmise that this trend continues to increase. So we're seeing increasing rates of antimicrobial resistant strains, but the problem is exacerbated by the fact that every year we have fewer and fewer tools available to combat these pathogens. Since 1969, there have only been 2 classes of novel antibiotics that have been introduced in the market. And this is highlighted by other reports that examine how fewer and fewer antimicrobial approvals are done every year. In a report by the CDC in 2013, they show that since 1980, the rate has dangerously been decreasing of new drug applications for antibiotics. So we have more antimicrobial resistance, and we have fewer antibiotics that are available for these agents. And development is slowing down. This has fostered the perfect climate for initiatives like Choosing Wisely to pay close attention to the issue of antimicrobial resistance and antibiotic overuse. They actually have a poster that they circulate to patients for whenever they asked by their physician to prescribe antibiotics, to ask these following 5 questions. Do I really need antibiotics? What are the risks associated with antibiotics? Are there simpler, safer options? How much do they cost? And how do I safely take them? And they ask patients to elaborate, that even if they're still being given an antibiotic, to clarify from their physician whether they even have a bacterial infection in the first place. So we've talked a lot about the concerns about antibiotic overuse, but what do our prescribing practices look like here? The Public Health Association of Canada uses comparative data to see how Canada performs compared to other comparable countries, in this case, many European nations. The y-axis uses a metric called the DDD. It's a standardized pharmacy measure for antibiotic prescribing rates. And with regards to outpatient antibiotic use, Canada performs similar to other comparable countries. With regards to hospital antibiotic use, we're actually performing better than many of our peers. But this is broad data that doesn't really have the detail to see how different hospitals are performing. This year, in a powerful study by Dr. Daneman in Toronto, he examined the variability of antibiotic prescribing rates between hospitals. There's a lot of information in this graph, but I'll walk through some of the pertinent elements. The y-axis, again, represents the rate of antibiotic prescribing. Each of the dots represents a different hospital. At your far left, you can see it's clustered by small community hospitals, followed by medium community, then large community, and lastly, on your far right, you can see teaching hospitals. This is where our institution lays. And if we just focus on that one part, you can appreciate that there's a spread in the cluster regarding how different hospitals perform. Some are clearly prescribing much more antibiotics than others. When I contacted the author, unfortunately, the data is de-identified, so we can't see where TOH lies within this data. The hope is in the future to actually tie data like this with information regarding the antibiotic stewardship programs of different institutions to see the effect that antibiotic stewardship has in different institutions. And you can imagine that there's implications about data like this regarding, for instance, performance measures and metrics of antibiotic overuse. The point is that we vary significantly from institution to institution in our prescribing practices, and clearly some centers are overprescribing more than others. What can we do as emergency doctors to tackle this problem? The American College of Emergency Physicians published a statement focusing on this issue in 2013. And they discussed that globally, clinicians practicing in the emergency setting must acknowledge and address the increasing problem of antimicrobial resistance stewardship. They continue to say that this requires emergency departments take an active role in designing and systematically studying strategies to improve antimicrobial stewardship in these settings. So they're saying that we need to be leaders in this. We need to take ownership about antibiotic stewardship. Now, what are we doing at TOH? In TOH, we're following the Public Health Ontario initiatives. They have 32 different strategies to tackle antibiotic stewardship. This talk addresses one of them, in particular, the preventing of treatment of non-infectious conditions. So with that, we'll talk about the clinical cases, and again, there's 3 of them where evidence suggests that the role of antibiotics might be questionable. The first case is that of asymptomatic bacteriuria, and we'll pay closer detail to that of patients with indwelling catheters. I want you to think about a patient that you're seeing in OBS, a 75-year-old male who's sent in from a nursing home with an indwelling catheter, who's sent in with a respiratory complaint. His urine is automatically sent because it's cloudy and it's foul-smelling, and the culture grows 10 to the 6 bacteria. How do you approach this patient or this result if you're the QA physician who receives it? So for this, there's a TOH protocol. It says that for patients with an indwelling catheter, we need to look at a couple things. We need to look at whether they have fevers, rigors, or delirium that is not due to any other source, or new CVA tenderness. If they have these, then we remove the catheter, we change it, and we take a new urine sample, and we send it for microscopy, and if it's positive, we treat with antibiotics. But if none of these features are present, there's no role for antibiotics, but there is no role for screening the urine in the first place. And this makes sense. When you think about it, patients with an indwelling catheter have a conduit that allows colonization of their bladder, and the bacteria travel up either intraluminally or extraluminally between the catheter and the urethra. Eventually, they form a biofilm in the catheter, and it makes the bacteria impenetrable to antimicrobial agents, hence why they require catheter change. We know that within 1 day of catheter insertion, 5% of patients will have bacteriuria. And this rate increases to 100% within 1 month. In a prospective study of over 1,400 patients, where they were asked regarding their symptoms and daily urine cultures and leukocyte counts were taken, they found that fewer than 10% of patients with bacteriuria had symptoms. I see Thara laughing. These are not dancing people. These are symptomatic patients. So the point is that everybody will be colonized eventually, but few patients will actually be symptomatic. And this is part of the reason why the IDSA defines the catheter-associated UTI as one where you have signs and symptoms compatible with it, namely, again, fever, rigors, new delirium, not due to any other source, CVA tenderness or pelvic discomfort, and you have a positive urine that grows over 1,000 bacteria from a good source being new catheter. Now, for a long time, people debated whether there was a role in treating bacteriuria to reduce its prevalence. And there are plenty of historical retrospective studies into this, but there is a randomized controlled trial published almost 4 decades ago. They included patients who had a positive urine culture and were asymptomatic and had an indwelling catheter. It was a small study of 35 patients, and they randomized them to either being treated with Keflex or a placebo. They were followed for about 43 weeks. What they found is that regardless of treatment or not, the prevalence of bacteriuria was the same. What they also found is that in the group treated with antimicrobial agents, the rate of antimicrobial resistance was significantly higher. 36% were susceptible to cephalexin in the cephalexin group versus 3/4 in the placebo group. So although it is a small RCT, the results show that antibiotics did not reduce further bacteriuria, and it did increase the rate of resistance. Now, others wondered whether treating bacteriuria can reduce the risk of bacteremia or mortality. The largest study that addresses this question was a retrospective cohort study. Their goal was to address these two questions. First, to establish what the relationship was between bacteriuria and bacteremia or mortality, and what is the effect that antibiotics has on bacteremia or mortality. Again, it was a retrospective study using an inpatient population, 5 inpatient wards, and included all patients who had positive urine cultures. What they found was that being symptomatic with bacteriuria, so that is what you see there as CA UTI, catheter-associated UTI, versus being asymptomatic, had an odds ratio of 2.8 for bacteremia, so it was an increased risk of bacteremia. But there was no difference in the mortality risk. Whether you received antibiotics or not had no effect on the rate of bacteremia or mortality. And they ran this analysis multiple times by either grouping all patients with positive urines versus those who were symptomatic and asymptomatic. There are some strengths of the study, namely that it is the largest sample size that tried to address this question, and it distinguishes patients who were symptomatic from those that were asymptomatic. But it's limited by the fact that it was an inpatient population that might differ from ours. They had a high rate of mortality of 21%, and this approaches ICU mortality in some centers, and it has the limitations of a retrospective study. Overall, however, antibiotics did not affect the rate of bacteremia or mortality in the study. Now, there is one RCT that has tried to look at this question as well. It was in the ICU population, and it is the most referenced study in the literature regarding this issue. They included 60 patients who were asymptomatic from a urinary point of view, who were not receiving antimicrobials, and had an indwelling catheter. And they randomized it to either being treated with antibiotics versus a control. What they found is that at 15 days, there was no difference in the rate of bacteriuria, in urosepsis, or mortality. And this is the only RCT of its kind that compared these outcomes. And it used useful endpoints like mortality and urosepsis rate. It is, again, limited by a slightly different population. Here it's the ICU population and is overall a small sample size and could be underpowered. There were also no standardized antibiotic regimens, which introduces some performance bias to the study. Still, all this evidence suggests that antibiotics have not played a role in decreasing the rate of urosepsis or mortality in patients with asymptomatic bacteria and an indwelling catheter. With regards to the rest of the population, those without a catheter, there's a Cochrane review that was published in 2015. It included 9 studies, and in total, this is over 1,600 patients. It excluded patients with an indwelling catheter, and out of these studies, only one of them was in the emergency setting. It was from 1969, and it was predominantly female in the study. I will just go through the forest plots of the Cochrane study to highlight how antibiotics performed. On your left-hand side, if the dots fall on your left-hand side, they favor antibiotics, and on the right side, placebo. You can see that there was no effect of antibiotics in the rate of symptomatic UTI, the rate of complications, or mortality. But antibiotics were associated with an increased rate of adverse effects. And this Cochrane review has the advantage of having a large sample size that included multiple studies of moderate to high quality. And it is the best evidence that we have available right now to guide our practice. However, only one of these studies was conducted in the emergency setting, and it was predominantly female. But still, I will highlight that the best of evidence that we have suggests that there's no role of antibiotics in asymptomatic bacteriuria. Now, when we see patients in the emergency department, often they're being admitted, and we wonder whether we should treat the urine culture and decide our colleagues in the inpatient ward to decide whether they need to continue antibiotics or not. What effect does this practice have downstream? There was a study published last year that tried to address this question. What they did is they looked at all patients who were admitted, who received antibiotics in the emergency room for UTI, and they determined whether the antibiotics were given inappropriately or appropriately. For this, they used the IDSA guidelines. So they needed to be symptomatic and have a positive urine to decide that the antibiotics were given appropriately. Out of those patients for whom antibiotics were initiated inappropriately, they looked at what proportion those antibiotics were continued inappropriately. And what they found is that out of the 94 patients that they looked at retrospectively, 55 of them, antibiotics were initiated inappropriately in the emergency department. And out of these, in 44 instances, they were continued. This represents an overall rate of 59% inappropriate antibiotic initiation in the emergency department and 80% inappropriate continuation once they get admitted. I know that the study is overall a small sample size, but I think it's fascinating that it highlights the downstream effects that our antibiotic prescribing and orders in the emergency department have. And our orders don't just stay within the ED. They have a ripple effect or a domino effect once patients get admitted as well. So when we apply all this evidence back to the patient that we have, that I put forth initially, a 75-year-old male with a catheter who has no urinary symptoms, the recommendations and our TOH protocol highlight that not only should we not screen this urine in the first place, there's no role for treating asymptomatic bacteria. We'll move on to the second case, that of dental pain without overt signs of infection. I want you to think of a patient you're seeing in urgent care. A 30-year-old female with a recent history of increasing dental pain. It's now unbearable, and her exam is overall unremarkable except for some percussion tenderness. Her teeth look like this, and she tells you that she has not seen a dentist in years. One of our recent graduates, Hassan Sheikh, actually wrote an editorial in the Toronto Star not long ago discussing this issue, mainly of the lack of available public services for dental pain for patients who have a low income. Some of the stats that struck with me is that every 9 minutes, a patient is seen in Ontario, in an emergency room in Ontario, with a dental problem. And the magnitude in terms of finances of this issue is $31 million annually. Data from the Ontario Oral Health Alliance shows that in 2005, in our LHIN, there were over 6,000 emergency department visits for dental complaints. What most of these patients have is pulpitis. Essentially, erosion of their dentin causes bacteria to cause an intense inflammatory response in the pulp. It is not bacterial invasion of the pulp itself. And the treatment for this is pulpectomy. And although we don't have guidelines in Canada from the Canadian Dental Association that have a stance on the management of pulpitis, there are multiple international bodies that do have recommendations and guidelines about this problem. Two of the ones that I want to highlight are those from the American Association of Endodontics and the Scottish Dental Clinical Effectiveness Program. These are really great brochures that serve as a good reference for dental problems. There is consensus that in patients with dental pain, antibiotics are only indicated if there is fever, trismus, swelling, or cellulitis, overt signs of cellulitis. And still, although there is consensus regarding this, prospective questionnaire data suggests that between 50% and 75% of patients with pulpitis are treated with antibiotics. Data from PharmaNet, which is a pharmacy database in British Columbia, showed that from 1996 to 2013, there was an increase rate of dental antibiotic prescribing of 62%. Now, Largely, this consensus is for dentists who are seeing patients in their dental practice. Is there any evidence that we can use for patients who are visiting the emergency department? This year, there was a systematic review published in the Annals of Emergency Medicine with a comprehensive search strategy, and it identified 2 randomized controlled trials that we'll look into more detail. The first one was published in 2000. It included 40 patients that were seen in emergency, and they were randomized to either been treated with penicillin or placebo. And again, these are patients who had dental pain, who were not immunocompromised, who had no overt signs of infection. They were followed for 7 days for these outcomes: their pain scale, the total amount of analgesia that they took, and a measurement to see whether there was vitality of their tooth, a surrogate to see how whether there was necrosis in their pulp. And what they found is that on follow-up, there was no difference in their pain intensity, in the amount of analgesia that they took, or in the proportion of patients that had vital teeth. This was the first randomized controlled trial in the emergency setting to address this question, and it used patient-centered outcomes. When we review some of the commentary regarding the study, it does suggest that the patients were not seen exactly in an emergency department like our own, although it is described like that in the study. But it seems like it's more of an emergency dental clinic. So you can argue that there might be some generalizability concerns from this point of view. It's also limited by the fact that it's a small sample size of only 40 patients. They did not report adverse events, and infection was not an outcome. But their results suggest that antibiotics did not reduce pain and they did not increase the vitality of teeth that were affected. There was a second RCT published 4 years later that addresses some of these limitations. It included 195 patients that were seen in an emergency department like our own, that were randomized to either being treated with antibiotics or placebo. Their endpoints included this time infection on follow-up. And again, what they found was that there was no difference in the pain of these patients, whether they were treated with antibiotics or placebo, but there was also no difference in the infection rate. This RCT had a larger sample size, and it was a population that was more reflective of our own. And they did report the infection rate, which is an outcome that we would care about here. It's again limited by the fact that they don't report adverse events, and 31% of their patients were lost to follow-up. This can cause some problems in interpreting the data. But together, the best evidence available suggests that antibiotics do not decrease the rate of infection and do not decrease pain in patients with dental pain and no overt signs of infection. So our patient that we're discussing, the 30-year-old female with irreversible pulpitis, the management for her would be to refer to a dentist and to not treat if there's no fever, trismus, swelling, or cellulitis. In the emergency room, we have a card where we can refer these patients to the Ottawa Dental Society. It's actually a self-referral service where patients call and they're seen by an emergency dentist between 9 a.m. and 9 p.m. Unfortunately, the service is not free. And as a result, most of the patients that we see with this problem are not able to access it. There are 2 available services that I could find in Ottawa for this instance. The first one is the Pro Bono Dental Clinic. It's led by Dr. Fong and a group of volunteers. It is another self-referral option where patients need to log online and fill out an application, but they do have a list of exclusion criteria, one of them being, for instance, drug use, like chronic drug use. Another option that might be more useful for us is the Homeless Dental Clinic. This is headed by Dr. Harley, and again, it's a volunteer group. It is in the Bauer Market, located in the Ottawa Mission, and it's another self-referral clinic, and it's open 8:30 a.m. to 3:30 p.m. When I called them, they told me that generally patients get an appointment between 1 week to 2 weeks from when they see the clinic, so this seems like a good option. The issue is that because it is a volunteer group, it is unpredictable what days of the week there might be a dentist available. We'll move on to the last case. that of uncomplicated diverticulitis. Think of a patient that you're seeing again in urgent care, a 50-year-old male who's previously healthy, who has first episode left lower quadrant pain, and is afebrile, tolerating PO, but his CT shows left-sided diverticulitis. How do we approach this patient? Well, we know that diverticulitis is a spectrum of disease. It starts as inflammation of diverticula, and it can range all the way to having an abscess that can rupture or fistulize. And traditionally, it was thought that the onset of the illness would be obstruction of the diverticulum by either a fecalith or a food particle that would cause increased pressures in the diverticulum, leading to infection. But more modern theories about the pathophysiology of the diverticulitis suggest that early onset disease has more in common with conditions like IBD, in that there's an interplay between underlying diverticular disease and chronic inflammation, changes in the gut microbiota, colon motility, and visceral hypersensitivity. Still, regardless of what model of thought you ascribe to, an uncomplicated case of diverticulitis is one where the patient is not septic and does not have complications. For these patients, what do the guidelines suggest that we do regarding their management? There are multiple bodies that have guidelines for this. The one that most surgeons subscribe to in Canada is the American Society of Colon Rectal Surgeons. They're thought to be the authority in all colon and rectal issues. Their stance is that all patients with acute uncomplicated diverticulitis should be treated with antibiotics. But more recently, in 2015, the American GI Association changed their stance. They now argue that antibiotics should be used selectively rather than unconditionally in all patients with diverticulitis. And this is a dramatic paradigm shift. The problem is that nowhere do they define who are these patients that we should be using selectively. So what evidence is there available to see who is this population that we can identify? Well, I want to highlight the two most important randomized controlled trials to address this question. The first one was the AVOD study in 2012. It was an open multi-center randomized controlled trial in Sweden and Iceland that ran over 7 years in 10 hospitals. It included adult patients with acute left-sided diverticulitis, and in total it was 669 patients that were either randomized to an observation arm or antibiotics. Importantly, all patients in both these arms were admitted, and this is a significant difference in practice compared to our own institution. They were followed up every couple of months and a year later to see whether there was any difference in their outcomes. What they found was that between the groups there was no difference in the rate of complications, emergency surgeries, their hospital stay, their follow-up surgery, or recurrence of disease. This was the first randomized controlled trial to address this question, and it was a large sample size. However, it had some significant limitations. One, all patients in the study were admitted, and this is not exactly the same as we practice here. Secondly, there was no standardized antibiotic regimens in the study. This is one of the criticisms by many surgeons. The exclusions in the study of the patients that were excluded are not well described, and there's large variability in the recruitment rates between hospitals. And lastly, and quite importantly, is that 40% of these patients had recurrent diverticulitis. The reason why this is an issue is because it's uncertain whether recurrent diverticulitis is a different disease entity than first episode diverticulitis. However, the authors conclude that antibiotics did not decrease the rate of complications, their length of stay, surgeries, or recurrence. There was a second study published this year, the Diablo Trial, that addresses many of these limitations. They again included adult patients with left-sided diverticulitis who had either Hinchey stage 1A or 1B disease. And the Hinchey is the staging of diverticulitis to try to qualify the complications present. And in this case, patients had either no abscess or a small pericolic abscess. They excluded patients that had previous diverticulitis, who were septic, who were immunocompromised, or who were pregnant. And in total, there were 570 patients that were randomized to either an observation arm or an antibiotic arm. What's also important is that the antibiotic arm was standardized to receive amoxiclav as per the ASCRS recommendations. And they also had defined criteria that they could use for the observation arm of patients that could be treated as an outpatient right away. They had to meet these criteria. Patients had to be afebrile, be tolerating a normal diet, had a pain score less than 4, had the same self-support capability as before the illness, and they had to accept to go home. In total, 13% of their patients were sent home right away from the observation group. What they found is that there was no difference in the pain scores in patients in the observation group compared to the antibiotic group. There was no difference in the proportion without recovery, and they defined recovery as patients that were discharged from hospital who were tolerating a normal diet, were afebrile, had a pain score less than 4 out of 10 without taking analgesia, and who had resumed pre-illness activities. They also found that there was no difference in the rate of readmission, complications, recurrence of disease, or mortality between these groups. This was a large RCT that really questions the role of antibiotics in this group. And they had a standard antibiotic regimens that recommended by the American Society of Colon and Rectal Surgeons. However, it's still limited by the fact that almost 90% of their patients were admitted to hospital. Their readmissions were not well described in either, and they included a small subgroup of patients who had a small pericolic abscess, and most of us would be very hesitant to not treat an abscess with antibiotics within the context of diverticulitis. So these two randomized controlled trials, which are the strongest trials available, suggest that antibiotics did not decrease the pain, time to recovery, rates of readmission, complication rates, or recurrence of disease in patients with acute uncomplicated diverticulitis. How would we approach this patient? Well, what I would advocate for is more of a shared decision-making process with these patients. There is still some differences in the population that where these trials were conducted compared to ours here at TOH. But I would put forth that there's emerging evidence that questions the role of antibiotics and that there's uncertainty whether it is the best course of action with them. I would have a frank discussion regarding the adverse effects of antibiotics in this case. The role is yet to be determined in patients with Hinchey 1B disease and recurrence. When I polled the surgeons here to discuss these studies, many were not aware of this last study that was just published this year, but when we discussed it further, they still had some concerns regarding the generalizability of the results. They pointed out that the inclusion of Hinchey 1B patients does not apply to our patient group here, and there was much skepticism about treating these patients without antibiotics. And they highlighted again that still most of these patients had a short admission to hospital, which is a difference in practice. Okay, I want to close by just recapping some of the things that we talked about. First, we explored issues regarding antibiotic overuse. And I want to highlight the statement by ASAP in that emergency department physicians should strive to be leaders in antibiotic stewardship and adopting this into our culture. We also discussed 3 cases where the role of antibiotics is questionable. In patients with asymptomatic bacteriuria, their urine should not be screened, and if they have a catheter, and if the urine gets sent and it's positive, they should not be treated. And this is true for all comers asymptomatic bacteriuria. The best evidence available for patients with dental pain without signs of overt infection is that there's no role for antibiotics either. And thirdly, it is controversial what the role of antibiotics is in patients with acute uncomplicated diverticulitis. in terms of going future directions or things that we can do going further, it would be useful to have an emergency department physician as a representative on the Antimicrobial Stewardship Committee here at TOH. There's a larger pharmacy and therapeutics committee that looks at what drugs and pharmaceuticals are going to be part of the formulary, but there's also a subcommittee that there's two ID physicians, Dr. Nod and Dr. Su, and a couple of pharmacy representatives. And I would put forth that it would be useful having an emergency representative here as a bridge between the emergency department and infectious disease and pharmacy. With regard to asymptomatic bacteriuria, it would be useful to review our practices of sending urine cytomatically in patients with indwelling catheters. I think that it would be very revealing to study what are the perceptions and expectations of patients with dental pain that come to our emergency department. Are they expecting antibiotics in the first place? And what are the factors that influence physicians to prescribe antibiotics? And lastly, I think that a definitive Canadian RCT is needed in a population like our own where patients with acute uncomplicated diverticulitis are sent home immediately. Before taking any questions, I want to acknowledge a couple of people. So Dr. Yadav was my supervisor for this, and he spent a tremendous amount of time reviewing my slides with me. Dr. Su, who I think is here as well somewhere, so she provided a great deal of advice on some of the data that I presented. Dr. Carter, Dr. Auer, and Dr. Lampron were some of the surgeons that I polled. Dr. Daneman is one of the authors of the study that looked at hospital antibiotic variability, and he's in Toronto, and we had many discussions about where this data can be taken in the future. And Dr. Roy is one of the dentists in the emergency dental clinic here at TOH who provided lots of information and insight regarding dental services. And Dr. LeBlanc, who I think came as well, so she's provided me lots of feedback regarding my slides throughout this time. So with that, I'll close and I'll take any questions.